our speaker. Dr. Andrew Ross is the clinical ethicist serving the Glenrose Rehabilitation Hospital, Edmonton's own suburban and rural acute care, community health and addictions, and emergency medical services. Andrew joined Alberta Health Services Clinical Ethics Service in 2017, having previously worked at the Covenant Health Ethics Centre and at the University of Melbourne Office for Research Ethics and Integrity. He completed his doctoral studies in philosophy at Queen's University, where he wrote his dissertation on exploitation of developing country participants in for-profit clinical drug trials. In addition to clinical ethics, he has a long-standing interest in research ethics. A native Calgarian, we're lucky now that he calls Edmonton home, recognizing he's also lived in Red Deer, Kingston, Montreal, and Melbourne. Without further ado, I pass it over to you, Andrew. Thank you again for being here.
Thanks, Michael, and thanks for that introduction. Thanks everyone for joining us today. I'm going to be talking about violence against healthcare providers, and as my title indicates, an elephant in the room. Not to spoil the surprise, but there will be one picture of an elephant in the slideshow somewhere. You might be able to spot it. As mentioned, I'm a clinical ethicist. In this recent reorganization process, our service has been relocated from Alberta Health Services to Health Shared Services, but essentially our coverage remains the same. So regardless of which pillar you now find yourself in, if you used to be part of AHS pretty much, then we also used to be part of AHS, and you can definitely still call us. And if in doubt, you can call, and we'll always pick up the phone, and we can certainly redirect people if absolutely necessary. But for most folks, we would be the place to come if you're needing ethics guidance or support or education. So, quick outline of what I'm going to be talking about today. I'm going to first sort of do a brief introduction, a little bit of definition work, and talk about what I think is a problem and a dilemma. And then we're going to talk about, why is it that we seem to focus on duty of care, even at the expense of provider safety. Then I'm going to talk a little bit about what can we do about this problem. And then hopefully we should have a pretty interesting discussion at the end. So start off a problem and a dilemma. So first, I'll just start, as Michael mentioned, I do have a philosophy background, so I can't start a presentation without giving a definition at the start. So here's a definition. I want to set the stage for this conversation by explicitly noting that I'm using a deliberately broad notion of what constitutes violence. So here's a definition that's taken from the Respectful Workplaces and Prevention of Harassment and Violence policy, and it's violence means the threatened, attempted, or actual conduct of a person that causes or is likely to cause physical or psychological injury or harm. And I've added that emphasis. I'm using this definition not only because it is the definition used in the policy, but also because it fits neatly with the contours, I think, of the moral problem. So violence is one of the many controversial claims I'm going to make today. Violence is ethically unacceptable. And it's unacceptable whether it's threatened, attempted, or effected. What makes conduct violent and ethically unacceptable, one of the things is that it causes or is likely to cause injury or harm. And that this includes both physical and psychological injury or harm. And importantly, this definition encompasses a broad range of threatening, aggressive, or harmful behaviors, and not just sort of physical attacks. So, problem. Violence in the healthcare workplace. This is a fairly recent news story out of Saskatchewan. But you could look back, any number of months and pick a month pretty much, and you could probably find a news story from somewhere about violence against healthcare providers. Unfortunately, this is not a new problem. There's literature about sort of the prevalence of it going back decades, and the problem itself likely goes back much further. Like I said, it's acknowledged to be widespread. Estimates vary, but a 2019 systematic review and meta-analysis found 61.9% of healthcare providers reported having experienced workplace violence at some point in their career. Um, we also think that it may be increasing. By some estimates, incidents of violence against healthcare workers actually doubled during the COVID-19 pandemic, from already being pretty problematic to just problematic and happening often, unfortunately. The other reason I actually say may be increasing is because this violence is widely thought to be underreported by healthcare workers for a variety of reasons, some of which we're going to touch on a little bit later. And finally, I just want to acknowledge right at the start here, there are not any easy solutions to this. If there were easy solutions, surely we'd have implemented these by now. Violence itself is kind of a complex social phenomenon with many different risk factors, and in a healthcare context, the response is particularly complicated. And as I'm about to argue, it may indeed involve at least one dilemma. So, just an example. This is it's fictionalized, but based on, unfortunately, a number of different cases that I've had contact with, where very unfortunate behaviors were being displayed towards care providers. So, patient called me a slur and threw something at me. Even my kindergarten partner, knows better than to behave that way. This kind of occurrence is all too common in the healthcare system. And I think it's worth picking apart this sort of claim a little bit here. Even my kindergartner knows better than to behave that way. So there are some basic moral standards that we expect of people as moral agents. And when patients are violent towards healthcare providers, such behavior falls short of how we expect people to treat strangers, let alone people who are actually providing care for them. So some might suggest that we simply not tolerate such behavior, which might be feasible in some instances if the violence is coming from a patient's family member, for example, and that family member doesn't have to be there for the provision of care, so they can just be removed from the site or banned from the site even. But it isn't that simple when the violent behavior comes from a patient with ongoing care needs. And so to see why it's not so simple, I'm going to briefly explain the concept of a moral dilemma. I know I said I would start with one definition, but actually I'm going to sneak in another definition here. And then we'll look at the arguments which form the horns of our dilemma. So what is a moral dilemma? The term comes, okay, I'll put on my philosophy hat again for a second here. The term comes from the ancient Greek, di meaning two, lemma meaning horns. And so for this reason, it's not uncommon for moral philosophers to talk about being gored by a dilemma. So a moral dilemma is a situation in which you have conflicting moral duties. And then here's a definition taken from the Stanford Encyclopedia of Philosophy. The crucial features of a moral dilemma are these. The agent is required to do each of two or more actions. The agent can do each of the actions, but the agent cannot do both or all of the actions. The agent thus seems condemned to moral failure. No matter what she does, she will do something wrong or fail to do something that she ought to do. And there's just the citation. So that's what I mean by a moral dilemma. So let's now sort of return to our problem of violence in the healthcare workplace, and I'll explain how it presents, at least one moral dilemma. And I'll do this by constructing each of the two sort of lemmas or horns in turn. And if both of those arguments are right, then it is a moral dilemma. So first dilemma, begin with this sort of the first horn. Access to healthcare is a moral right, and in Canada also a legal right, rather than a privilege. And as a result of that, duty of care to a patient is owed based on that patient's need, not their moral merit or moral deservingness. Even people convicted of serious crimes still have rights, including the right to healthcare. And we, can often see this in acute care facilities. We often get people being transported from prison to receive treatment. So follows, therefore, that we still have a duty to care for the violent patient. Now, let's look at the other horn of this dilemma, the other argument. Every person has a moral right not to be harmed by other people and a moral duty not to harm other people. And yeah, I said I was going to make some controversial claims, and here we go. Here's another one. This actually, I think, is so uncontroversial that if we found a moral theory that didn't hold this to be true, it would sort of be, if not disqualifying, it would immediately make us suspect that actually there's got to be something wrong with that moral theory. And here's maybe the most controversial claim I'm going to make today. Healthcare providers are people. Um, I don't know if it's coming across, but my tongue's firmly in my cheek for that one. Like, obviously, care providers are people. And it therefore follows, like actually pretty much trivially follows, that care providers have a right not to be harmed, even by patients. Now, I will note that any philosophers in the audience will recognize that I am simplifying these arguments a bit here. For the moment, I'm going to gloss over the fact that this dilemma is technically more of a dilemma for the healthcare system than for an individual provider. It's the system that has the duty to ensure every patient receives needed care and the duty to ensure care providers are safe at work. But we will come back to this. So, the dilemma. This violent patient has a moral claim to receive needed healthcare. Healthcare providers have a moral claim to not be harmed by others, including the patient. So, how should we weigh these competing claims? What makes this at least a prima facie dilemma, or at first glance, at least appears to be a dilemma, is that we have two apparent duties. We maybe can't fulfill them both. Or put another way, there seems to be a choice between two options, neither of which is morally okay, because continuing to care for a violent patient puts care providers in harm's way. But if they stop providing care, then the patient will be harmed. So how we I'm going to talk about and I put a little star there, our typical response. To be clear, I'm very much including myself in this group of our. And in fact, I'm going to be using some pictures of slides from some of my own presentations on this subject as sort of illustrative of this sort of typical response. So the typical response, first of all, often emphasizes the duty of care and the fact that this duty persists despite the patient's behavior. So just some examples. The persistence of the duty of care is relevant, and it is a big part of what makes the problem of violence in the healthcare workplace theoretically interesting, because in many other contexts, worker safety might outweigh a violent person's claim to receiving service, for example. But frankly, this is not news to healthcare providers. And in my experience, it's not generally something that they actually need to be reminded of. So some more slides from one of my presentations. Often I would talk about the importance of compassion, of building trust, of taking a trauma-informed approach to understand where the patient is coming from. So we talk about things like changing relationships and the importance of compassion, and that it's observable, and that the presence or absence of compassion is sort of detectable by others and can impact the trust relationship. Again, these things I don't want to suggest that these are not important or not relevant. I think they are relevant and they are important. But I also feel like actually telling healthcare providers about the importance of compassion is a little bit like telling a group of chefs about the importance of seasoning. The audience pretty much knows that already. Another thing that I'll point out I certainly I have been guilty of is, when talking about healthcare provider safety in this context, I often mention the fact that, when we're talking about safety, providers need to be safe. And one of the reasons they need to be safe is, because it's a prerequisite, to be able to continue to provide that healthcare. Um, in discussing the importance of safety, I have sometimes used the analogy of putting on your own mask first before helping others to put on their masks. And while that analogy isn't exactly wrong, I've come to fear that it maybe sends the wrong message to healthcare providers, and maybe is sending the message that their safety matters mostly because it enables them to continue to provide care. So, my concern is that people might be taking away the message that actually it's not that you matter because you're a person. It's, your safety is important because you're a resource, and you have instrumental value. Uh, so, unintended consequence of this sort of typical approach, I think that these responses may send or reinforce a message to healthcare providers that their own safety is less important than or outweighed by their duty of care to patients. Now, I do want to say this is not what we, or at least what I mean, but I do worry that it can come across this way. And this may make it seem like this sort of dilemma or apparent dilemma of provider safety versus duty of care was only, in fact, an apparent dilemma and can be solved. And can be solved by concluding that, maintaining provider safety only matters when it doesn't conflict with meeting patient care needs. Unfortunately, I would argue that in practice, our actions and attitudes often actually do align with this mistaken interpretation. So let me give an example. I can recall a situation where I was debriefing a group of healthcare providers who had been experiencing violent behaviors from one of their patients. One provider said something that really sort of struck a chord with me. She was physically very pregnant. I think she mentioned she was like 8 months along. And she shared that, she viewed the risk of violence toward herself quite differently now, that because it might also harm her unborn child. And the other providers in the room all sort of reassured her that this was fair to be concerned about, and that it was not right for her to face the risk of violence in her current circumstance. And what was striking about this was the fact that she didn't seem to think that it was a moral problem that she faced the risk of violence until she became pregnant, and it was affecting not just her. And in fact, I noticed that each provider in that room seemed much more concerned about the ethics of other providers experiencing violence than about experiencing violence themselves. And I realized at that moment that I really needed to point out to this care team that, in fact, it's not right or okay for any of them to be subjected to violence at work. So that's sort of the message I'm hoping to emphasize today as well. So returning to the dilemma. I do want to emphasize at this point that I think it is a true dilemma and not only an apparent one. And what makes such problems difficult is precisely that we must try to uphold both duties, even though we may not always succeed. But yeah, I've sort of bolded this second one because, again, I think this is the one that people need to be reminded about. And in this light, I want to rephrase the question as well that comes out of this dilemma. Rather than sort of talking about weighing these claims as if, one would trump the other, I think it's, I want to choose my words a little bit more carefully and say, how do we balance these competing claims? Because we may not be able to, realistically eliminate violence from occurring. Like, this is just probably not a realistic goal to have. But that also, the fact that we can't get rid of it entirely doesn't mean that it's okay when it does happen. It just means that, we are in an unfortunate situation. So, since both claims are valid, we must try to balance them as best we can. Put another way, patients and providers are of equal moral worth. And the provider's need for safety is equally as important as the patient's need for care. And at this point, I'm also going to return to something I glossed over earlier. Technically, this dilemma is really a dilemma for the healthcare system rather than any individual healthcare provider. And part of the reason for that is because an individual healthcare provider only has a duty of care to their own patients. And they can transfer this duty to someone else, which they do at every handover. The system is responsible for ensuring the care of all the patients. And the system is also responsible for ensuring the safety of all providers. So, given this, I want to dive in a little bit into, you know, why is this? Like we've established now that this problem entails at least one moral dilemma, which is the need to ensure even violent patients receive needed healthcare while also needing to ensure that healthcare providers are protected from violence. But as I've highlighted, we, myself very much included, tend to focus more on one horn of this dilemma than the other. So why is that? In this section, I'm going to review a number of potential factors. I don't think any of them sort of fully explains it on its own, but I think each of them may sort of contribute to this net result. So, first point, the duty of care is more theoretically interesting. It's unusual, for one person's violence toward a second person not to diminish that second person's obligation to help the first person. Also, and I did promise there'd be one elephant, here we are. It is ethically uncontroversial to claim that violence against healthcare providers is wrong. This follows trivially on every plausible ethical theory simply because they're persons. But much like the proverbial elephant in the room, we can become so accustomed to ignoring this fact or just not talking about it that we cease to notice that we're not talking about it, that we're ignoring this. Second factor, nuances can be confusing, so sometimes we simplify and sometimes indeed oversimplify. So going back to that definition of a dilemma, a classic moral dilemma involves one agent with two or sometimes more mutually exclusive options and an obligation to do both things. So in this case, though, the dilemma properly described involves an abstract agent, which is the healthcare system. And part of why this is confusing is because an individual healthcare provider also has a duty of care to their patients, right? Much like the system has a duty of care. And an agent, including a healthcare provider, can waive their own rights. So if we think of it as a dilemma for an individual healthcare provider, then it maybe wouldn't be a true dilemma because there is a solution available to them. They can waive their own right to safety in order to ensure the patient receives needed healthcare. And I just want to be very clear. I'm not trying to say or suggest that they should waive their right to safety, or that this is reasonable to expect. This would be what philosophers call a supererogatory, which just means over and above that which is required by duty. Unfortunately, this is all too often exactly what does happen in practice. Third factor, and it's a big one, I think, is the culture of healthcare. Because it's all too common for healthcare providers to sacrifice their own safety, this can become normalized or even expected. You hear things like it's part of the job. I think I had a clip from a CTV article earlier, and one quote from a nurse in that article was that, sadly, it's the expectation that we are to take the form of abuse while expected to deliver the most compassionate and high standard of care. Healthcare providers are often encouraged to be resilient, and so to if you're complaining about violence, particularly if it's something other than physical attack, people can be concerned that they will be perceived as not being resilient. And there's also a tendency to focus on the healthcare provider's actions prior to an incident. And this is from a different news article about violence. This is from actually the president of the Saskatchewan Union of Nurses, who says, If you point a gun at a cop, you're going to jail. If you do it at a firefighter, it's the same thing. But if you do it to a nurse, they ask what we could have done differently to de-escalate the situation. So um, there's also, I think, some broader social factors. I'm not going to get too deep into this, but if people are really curious, shoot me an email, and I'm happy to send some references as well. Um, but very very high level, very broadly, the healthcare workforce is predominantly female, and there's a long and sadly ongoing history of greater social tolerance of violence towards women. Um, uh, Wish it weren't so, uh, but it is. Um, and this is also compounded by intersectionality for racialized folks, for sexual and gender minorities, people with disabilities, immigrants, people with lower socioeconomic status, other marginalized groups. And I will just note society sort of, I'm not saying that society says it's okay to be like violent towards certain groups, but there's a comparative tolerance of violence towards certain groups. So it's not that it's fully tolerated, but and often it's not explicit, but rather implicit. So it's things like you might see sort of lower rates of charges being pressed, lower rates of prosecution when there are charges pressed, lower rates or lower sentences as a result of these sort of crimes. Um, and again, usually not explicit reasoning, but the patterns are sort of there to suggest that this is a factor. And actually, I will just add one more bit on this, which is that I think, and I don't have good numbers to back this up, but anecdotally, in my experience, uh, violence in the healthcare system does disproportionately seem to affect, or at least in the cases that I have seen, the people who have been the victims of that violence have disproportionately been um, they've disproportionately been women, they've disproportionately been racialized, they've disproportionately been those in lower social economic status. So though it's more often nurses than physicians in my experience, and it's more often healthcare aides than nurses. Not to suggest that violence towards anybody is okay. Well, just to be crystal clear, it's not. Another factor, perceived asymmetry of vulnerability. So the focus often has been the vulnerability of the patients who need care, and I mean this is not wrong or uncontroversial, or sorry, not wrong, and it's not controversial to say that patients have vulnerability. That's true, and this is why healthcare providers have fiduciary duties to patients. However, I also want to suggest that it's not totally asymmetrical. There is vulnerability going in the other direction. Healthcare providers can also be vulnerable, particularly if they sense that acceptance of violence is expected as part of their job. And note that so long as providers believe that they're expected to accept violence as part of their job, they are made vulnerable, even if that expectation isn't real, even if management doesn't actually expect them to accept violence, for example. So, look at all this. I'm going to suggest there's also a bit of a vicious cycle. So, healthcare providers experience violence, but they accept it in one way or another. They minimize it. They don't report it. They just sort of try to brush it off. This then sort of sends the message to the system that violence can be tolerated to ensure that care needs are met. The system has these two duties that are in tension, but if the system is sort of getting the message that actually you this duty you can ignore, well, then that makes it simpler for the system. Also, I believe this, sends the message to other healthcare providers that acceptance of violence is normal and even expected. Then that means that it's more likely that healthcare providers will actually accept violence in the future, sort of reinforcing this whole pattern. So um, that was maybe the most depressing part of this whole topic. But now for the mildly hopeful section. What can we do? And I do want to say, in keeping with today's theme, I'm not really going to go over all the mitigation and prevention and relationship building strategies. This is not because they're not important or effective or valuable. I think that they are important, they are effective, and they are valuable. But the reason I'm not going into detail in those today is because they have been well covered elsewhere. And you know, if those of you who work in healthcare, you probably have heard about them by now, perhaps many times. So instead, today I'm going to focus on provider safety. And I want to just start by saying the first thing you can do is to ensure you're familiar with your local code white protocol and that you follow it. You know, as needed or available, involve other care providers, call security, call law enforcement when these things happen. You know, I've spent a lot of time in hospitals in my career, and you know, I couldn't tell you how many times I've heard code yellow paged or code red paged or code blue paged. I was thinking about this the other day, and I can't say for sure, certain that I recall ever hearing code white paged. Probably I have, but it's certainly way less common to hear than those other codes, and I don't think it's because the occurrence is so rare. I don't know what to do with that, but just to say, you know, we do have some codes and procedures, and you know, it's important to know them and to follow them in the moment. Once the violent incident is over, the next thing we can do is document, which I know this is especially for the care providers in the room, telling them to document. Again, I realize that I am telling the chefs to season, but um, first and foremost, while it is a pain to fill out forms at the end of what was certainly already a tough day, it's so important, vital, I would say, to report all incidents of violence towards healthcare providers. Whether that's you know, when it's affecting patients that goes or visitors that'll go in RLS, and when it's affecting care providers that goes in my safety net. This is the first step in breaking that vicious cycle that we were just talking about. It's also how leadership comes to know the scope of the problem, without which knowledge they simply can't be expected to marshal appropriate resources to respond to it. Also, in much smaller print, because I think it's not, you know, I'm not trying to emphasize it nearly as much, but it is also important to, you know, ensure that, you know, the care plan is kept current and includes specific strategies that have proven helpful in this case. So, you know, if you know, the longer that we care for a patient, the more we get to know about them, about what, you know, may trigger such behaviors, making sure that, you know, everybody on the care team knows, you know, what we all know. It's really important to you know, make sure that everybody has the best chance of avoiding or preventing that experience of violence for themselves. Next, I also want to say, so important, and this one I do emphasize in my normal presentation, but I also think it bears repeating here, is you need to look out for yourselves and each other. You matter, just for being you, just for being a person. You have moral worth, moral relevance. You matter. Your safety matters. And so please take your own safety seriously. Um, it's it's I know, you know, there's a whole culture that suggests that you shouldn't, and I am just one voice saying you should. But if you can find a fault in my argument, with claiming that care providers are people and people shouldn't be victims of violence, I would love to hear it. I think it's pretty ironclad. Um, Also, the each other part is very important, providing that mutual peer support to others experiencing violence. Peer support can make a big difference during difficult times. Um, we often talk about taking a trauma-informed approach towards patients, but I've not often heard of that lens being used towards our fellow care providers. Yet violence can certainly be traumatic. So I think it's worth exploring how you as care providers can transfer some of those trauma-informed care skills to apply them both to peer support and even to self-care. Also, I want to say, please do speak up when you hear others saying things that minimize or normalize violence towards care providers. And this can be tricky, can be awkward, but I think this sort of upstander effect is really relevant here. So it's as awkward as it might be for you who isn't directly involved to pipe up and point out that we're minimizing or normalizing violence in a way that's not right. Might be awkward, but it might be actually much less awkward and more heard than if it's coming from the person who is sort of directly involved in that situation and who is being having it suggested to them that this is normal or part of the job. And third thing that I'm going to say, and this is the maybe the slightly more controversial section of the presentation, is I think people should consider stronger responses when appropriate. So not to say that these should be the first step in every case or anything like that, but I think oftentimes we sort of preemptively take some of these options off the table, and I don't know that that's right either. So, like all workers, healthcare providers have a right to refuse unsafe work. And I would refer you to the WHS Dangerous Work Refusal Program page on Insight for details. I'll put the link in the chat at the end here. Um, Refusing unsafe work is your right. And it also reinforces the system's responsibility to mitigate those risks for workers. If someone commits a criminal act against you, whether that's assault, whether that's uttering threats, um, it, you know, it, you have the right to press charges, even if they are a patient. Not to say that pressing charges, is always going to be the best choice for every provider in every situation. I think the context matters, and what's right for you matters too. So I don't want to suggest that you're doing wrong by not filing charges in a particular or pressing charges in a particular instance. But I do want to highlight that this is an option that is open to you. Um, Again, even if it's a patient. And then lastly, this is a different example from a different recent news article. Um, there's more extreme response recently taken by nurses at two hospitals in Manitoba last year. And their union actually voted to gray list two hospitals. So a gray listed facility is one in which union members are discouraged from working. They're discouraged from taking a post there due to workplace safety concerns. And so this is obviously a more involved and extreme option. This is not going to be an appropriate response to a single incident necessarily, but this is more where there's been a pattern of incidents and reports have been made and there hasn't been much change. This is a lever that is available for unionized providers at least to press on to try to pressure the system into taking its responsibilities to worker safety more seriously. So resources. There are just a ton of resources meant to help providers facing violence, from everything from education to prevention strategies, mitigation strategies, post-incident supports. I'm going to post some links in the chat in a moment here. I'll just name the Managing Challenging Relationships guide here that right in the front. Uh, that's that's from my team. I think I'm obviously biased, but I think it's quite good. A lot of strategies in there um, for sort of prevention, mitigation, managing things when things start to go sideways, and ultimately protecting safety when that's the steps that need to be taken. It also has a checklist of strategies. Probably a lot of these will be things that your team has already tried if you've been dealing with these kind of situations for a while. But sometimes it also is just reassuring to see that, in fact, yeah, here's the checklist, and we have already tried all of these things, and to get that reassurance that actually we have done our due diligence, and we do need to sort of escalate this to get more support because we've tried everything that we can try at our level. So, as I mentioned, I will post those links in the chat. And uh, amazingly, I think we've actually sort of finished just about on time for the presentation section here. Uh, and we can hopefully move to some discussion. I'll just copy these links and chuck them in the chat as well.